Assalamu alaikum. I, Dr. Altaf Hossain Riad, Registrar of Radiation Oncology, National Institute of Cancer Research and Hospital, welcome you to my today's presentation on exploring the factors associated with treatment non-adherence in women with breast cancer at a tertiary care center of Bangladesh. So, breast cancer is the most common cancer in women and fourth most overall in Bangladesh. So, it's being a major public health problem, and treatment non-adherence is the key factor behind the poor outcomes, making it crucial to understand the reasons for dropout in order to take corrective actions. So, objective of this study was to identify the socio-demographic and clinical characteristics of women with breast cancer, to determine the prevalence of treatment non-adherence in the study population, to analyze the association between socio-demographic, clinical, and treatment-related factors and non-adherence, and to evaluate the association between non-adherence and doctor-patient relationship. So this was a cross-sectional study conducted at Khulna Medical College Hospital from June to September 2024 with the patient of breast cancer who has never been treated or discontinued treatment and at least 6 months has been passed, and patients who completed their planned course of treatment were also included as control, and data were collected through a questionnaire. So total 323 patients attended the outpatient department of Khulna Medical College Hospital from the proposed time duration, and 205 patients excluded as they were on the first line treatment, and 118 patients remained. Among these 118 patients, 48 patients had dropped out or discontinued their treatment, and 70 patients had completed their planned course of treatment. And from the 48 patients, 11 patients had only surgery, 13 patients had chemotherapy only, and 24 patients had both surgery and chemotherapy, but none of them received any radiation therapy. So the questionnaire has 3 sections. Section A contained the demographic and clinico-pathological information. Section 2 contained the key factors associated with treatment non-adherence, which was reported by the patients, and the section C contained patient reaction assessment score. There were several socioeconomic, cultural, or treatment-related barrier or reasons for non-adherence, like low income, limited access, long waiting time, lack of support, misconception, reliance on traditional medicine, or treatment-related fear. And the response were recorded as yes or no, and multiple responses were accepted. PRAD, Patient Reaction Assessment Scoring Tool. It's a scoring tool to assess the doctor-patient relationship having 5 domains like trust and confidence, communication, empathy and respect, shared decision-making, time and attention. It's a Likert scale, 5-point Likert scale rated on 1 to 5, having a total score of 25. These are the socio-demographic characteristics of the patient. So, except the district and the religion, most of the factors were well balanced. These are the table showing the clinical characteristic of the patients, and most patients had symptom more than 3 months. More patient with stage 3 and node positive disease and ERPR positive was more common. But the important is lots of patients had unknown ERPR status. This is the year-wise distribution of the dropped out patients. But I can say that this may not represent the actual scenario, as the data were not collected from an electronic registry. So this is an important slide, as this slide is showing the main reasons, magnitude of the reasons behind treatment dropout. Obviously, the financial constraint was the highest response among all other factors, but we can't ignore the other factors also, like preference of alternate medicine and fear of oncological care. Because around 50% patient responded these 2 factors as a reason for non-adherence. So the treatment non-adherence is not a single factor dependent, and these 2 factors also exceeded the lack of access and long waiting time. So I think it's our patient discontinued treatment. Obviously, financial reason is a major cause, but this is not the all. I think we need to understand this. So we tried to see the association between socio-demographic variable and dropout rate and found that the patients who from urban residents and family members having 5 or more, lower education like primary or below, and financial dependency had more dropout rate. And among the clinical characteristics, patients who presented more than 3 months from the onset of symptom had more dropout rate. So, two diagram here. The box diagram is showing the mean, and box diagram is representing that the median and interquartile range of the PRID score of the patient who did not interrupt their treatment was much higher than the patient who interrupted. And this line diagram showing the overall distribution, and you can see there is a clear distinction between the non-interrupted group and the interrupted group. And the difference were tested statistically, and it was highly significant. So the PRID score was more lower in the patient who interrupted that treatment. So patient who interrupted that treatment, doctor-patient relationship was, I can say, worse. So there are several limitations, but I think the unavailability of an electronic population-based cancer registry was the key limitation, and we could assess the better dropout. We could assess the actual dropout rate if there was an electronic registry. But I think still we have some valuable findings, and we can understand that we need to work on a lot of areas like infrastructure, insurance policy, screening, awareness program, and we can set up a personalized treatment care. We can set up some social support group, patient education. But what could be done at individual level? I think those factors are some social responsibilities and some nationwide responsibilities. But what is the responsibility of us as an individual? We could treat our patient with empathy and more patient-centered approach. And I think we can counsel them, and if we can do that, I think the dropout rate will be lower. And if one of us can prevent one dropout in a year, I think the effect will be compounded and much higher. So thank you very much for your patient sharing. Thank you.